Hello and welcome to Ask Alumni, the podcast where we talk to alumni of Loma Linda School of Medicine to gain insights and information to help students and young alumni on their medical journey. Hello, I'm your host, Calvin Chuang, and today we're going to be talking about the wonderful world of OBGYN, obstetrics and gynecology. And to do that, we're going to be talking to Elmar Sakala, Loma Linda University class of 1973B. Dr. Sakala, welcome to the podcast.
Thank you, Calvin.
Now, you are an OBGYN. It is a pretty common rotation for many students and those out there. But could you just describe to me, for those who do not know what OBGYN is, could you describe that to me as well as your specialty in maternal fetal medicine?
All right. OBGYN is dealing with the female reproductive system. And so it looks at pregnancy and non-pregnant status. My particular subspecialty area was maternal fetal medicine, which is high-risk pregnancies, which may mean complications, medical complications of the mother, but also fetal diagnosis of abnormalities and managing those through the pregnancy and delivery. So that's my particular area of expertise.
Okay. Now, how did you decide when you were in medical school? How did you decide, this is the specialty that I want to go down?
Well, it's interesting. I was originally interested in psychology and psychiatry. But when I got here and I was exposed to all of the Freudian teachings, I said, I'm not too sure about that. And the other thing is I like to do surgery, but not all the time. I like to have old people. I like to have young people. I like to have acute care. I like to have ongoing care. I like to have feelings and emotions and family. OBGYN fit all of those. Some people call it's a mix of surgery and medical treatment.
Okay. So you mentioned it's a mix, surgery and, patient care. What percentage do you think, would you say that you're in your current setting or in the settings that you have been in the past, you're in the operating room? And what percentage would you say you're doing other things outside of the operating room?
I would say that outpatient would be a good 70%.
Okay. With
30% being in the operating room.
Okay. And I gathered from what you've just mentioned that's one of the things that you enjoy about your specialty. What are the other things that you really that you enjoy about being an OBGYN doctor?
Delivering a baby.
Yeah?
Most of the time when you take tissue out of a human being, it's diseased. You send it to pathology. It's not wanted, but to see a newborn, a life coming out of a mom, even after 40 years of practice, it is still exciting to me.
What was it like when you caught your first baby? What was that experience like for you?
Well, that was interesting because as a third-year medical student, I went to Los Angeles to one of the hospitals there. And one of the residents was covering the obstetrical deliveries in a nearby hospital. And he told me, okay, we have two women who are probably going to be delivering at the same time. I'll deliver one, you deliver the other. Oh my. It was just absolutely inspiring. Needless to say, I was very nervous. But everything worked out very well. That was my first delivery.
Nice. Now, as someone who does deliver a lot of babies, do you often run into walking down the street and someone's like, "Oh, you're the person who delivered me"?
All the time. In fact, it is very unusual that I would go to a shopping center and I don't meet someone who says, "Oh, Dr. Sakala, do you remember me?" And you know what I end up telling them? I don't recognize you with your clothes on.
Nice.
But it is rewarding. I have one family, they have sent me Christmas cards of their children every year for the last 30 years.
Wow.
It is just amazing how grateful and how thankful they are.
Wow.
I mean, this is a gift that keeps on giving. A child will grow up and live for, decades and bring joy, hopefully, to the parents.
Right. And that sounds like it would be very fulfilling as an OBGYN. Now, obviously, there's a lot of fulfilling aspects, and you've talked about some of the things you like. What are some of the challenges about being an OBGYN?
Well, number one, with obstetrics, dealing with pregnancy losses, dealing with infertility, wonderful couples who would love to get pregnant and just cannot. Or you have a fetus that dies in utero and you have to deliver this stillborn baby and present it to the parents who had their nursery all made up, all ready for a newborn, and it's not to be. And then on the gynecology end, we're dealing with female reproductive tract cancers. And those can be very difficult as well. So there are those moments which are high on the mountain peak, and there are also those lows. Absolutely. Of course, that's true for every specialty.
Mm. And they're quite some heavy times. Is there any kind of consolation or solace or words of comfort that you found that have worked really well for those who have undergone such loss?
It's interesting just being there. I mean, you can't say, I know how you feel, because obviously I don't know how they feel, but I can say that I'm going to be there with you. We will not leave you through this. And we have set up at the hospital a nursing contact, which goes on for many months and years to maintain make sure that they're recovering from the grief and from the loss. But those can be difficult, no question.
Now, what about yourself? I mean, you're dealing with, all the joys of delivering, but also all the heartache and loss. As a physician, does that take a toll on you?
It does. It does. You try to keep a professional distance, and that's, of course, important. But it's very difficult not to take some of this personally and to think, what could I have done to prevent it? Maybe I didn't do this. Maybe I didn't do that. So there's a lot of that soul searching that goes on. But that's part of the practice. And you just have to learn to deal with that. There are specialties where there's no patient contact at all, like radiology and pathology. And if you're afraid of having heart-to-heart relationships with patients, you better not go into OBGYN, because those women, I mean, when you see a woman every month, and then every couple of weeks, and then every week until delivery, it is probably a closer relationship than you would in any other area of medicine.
Mm-hmm. Yeah. I'm guessing you've learned techniques over the years to help with that. What does self-care look like that has worked for you?
That's a tough one to deal with. Let me give you an example. You're on duty at the hospital for overnight call, and you followed a patient through the night. It's ready for you now to leave and to go home to your child's birthday party or to the baseball game which your child is in. And you come to the patient, you say, I'm going to have to leave now. And the patient says, you can't leave me now. After being with you all through the night, you're going to stay, aren't you? And you have to learn how to say, I wish I could, but my partner will be coming on and I have full confidence in them. And you have to walk out.
So that there is that almost juxtaposition then, hey, of like trying to leave as much emotional, emotion or your work stuff at work and your personal life at your home.
When I hear doctors say, I'm so busy, I don't have time for my family. Hey, you're the one that decides how many patients you're going to see. You're the one that decides your schedule. And when you let it go out of control, don't blame the patients. That's tough to do, particularly when you want to please, you want to do good things, and you get that immediate reward, that feedback. It's sometimes easier to do that than to go home and to face reality. My wife doesn't call me doctor. She doesn't know. She knows that I don't walk on water, but many patients think I do.
That mentality is fascinating. So yeah, you're kind of in some ways like a superhero in a work setting. Does that sometimes that kind of gratification and feedback you get, does that sometimes have to be something that you have to actively manage?
You do, absolutely. Because when you get to think that you're the number one, the king of the castle, one thing that I have all my career done is to support nurses and feel that they are part of the team just as much as I am. And the idea of a hierarchy where I'm the boss and you do what I tell you to do, that's not how you do it. So you have to work together as a team, and teamwork. I would rather, in selecting a resident to take into our residency program, have someone who is maybe not the top of the class, but to take them over someone who is the top of the class, but they think that they are prima donnas. They can't work with anybody else. You need to be able to work together.
Mm-hmm. That's very important. And some really good advice for students who are going to do their interviews. Are there any other tips you would say to give students who are trying to maybe get into OBGYN during their interview that they could to bring in and to keep in mind?
You need to always look at the context in which you're in. Different hospitals, different programs will have different emphases. And you need to find out what they're looking for. Some programs are looking for those who will do research and academic work. And if that's not your thing, you're better off to go to a community program rather than a academic medical center.
Mm. Now, how long have you been in OBGYN for?
How long?
Mm-hmm.
40 years, over 40 years now.
Wow, long time.
43, actually.
Wow. And in those 43 years, has the field changed much? Has it evolved?
Oh, absolutely. And probably the number one that I can talk about is ultrasound. When I started back in the 70s, ultrasound was just beginning. And the images that were produced were very shoddy. I mean, you had to really have a rich imagination. Nowadays, we have such clarity. We can see in utero things that we never saw before. And we can measure things that we never had before. So ultrasound has been probably the number one. And maternal fetal medicine specifically does a lot of obstetrical ultrasound.
Interesting.
And another one is OBGYNs were the first to bring in laparoscopy, which is minimally invasive surgery. Instead of making a big incision, you make a few small incisions and put a scope through. And that has really grown to now we can do laparoscopic assisted hysterectomies, taking out the uterus. It's just been marvelous.
And as this technology has come, all these techniques have come about, I take it that, as an OBGYN practitioner, that you would have to continually keep yourself up to date with these things? Absolutely.
And here's what I tell the residents. You need to change your practice as the scientific journals show you should. I used to go out to the community around Loma Linda and give continuing education courses to the doctors. And I can remember very well one doctor who I had explained what the newest recommendations were. And he said, "Thank you, doctor, but I'm very comfortable the way I do it. And that's the way I'm going to keep doing it."
Wow.
And he's practicing as he did in the last year of his residency. He doesn't look at the literature. He doesn't look at the journals. He doesn't look at the scientific reports. That's a tragedy. And I see that currently in the COVID epidemic and how the changes from the recommendations from the CDC, the Center for Disease Control, some people look at that and they say, "You're flip-flopping. You're changing what you said from before." That's science. That's medicine. Things will change, and we need to change with the times.
That's an interesting perspective, because it's a nice reminder that medicine, it isn't just hard and fast. It's not physics. Gravity doesn't stay the same kind of thing. It's constantly evolving, and as a physician, you must keep up with the evolution as well.
You may find in some of the professional journals back-to-back articles which have opposite conclusions. How can that be? Well, that's part of what science is all about. And so as studies replicate, you will find out who was true and who was false. But you've got to change with the times.
That last point is interesting to me, because there is a lot of in today's climate research that goes for or against certain techniques, certain recommendations. How do you, as a practitioner, kind of like decide which of this research is the one that you're going to abide by?
Well, it's interesting that when you have opposite conclusions, then you need to look at how the study was done. What was the methodology? What was the selection of patients? What were the criteria that they used? And that can sometimes explain it. But what I say is the professional organizations, such as the American College of Obstetrics and Gynecology, keeps up on a regular basis, updating recommendations, pulling together a consensus. And so I say, don't be the first to take up the new, neither be the last to lay back the old, but stay with the middle. And I think you'll be safe.
Okay, nice. Now, you've been practicing so long, over the 43 years of experience that you've been through. Is there anything that you would have liked to have known, or you would like to have told yourself back, when you're a med student, when you're a resident, that now, just given all the experience and knowledge that you've had?
That's a good question. OBGYN is a specialty that has concerns about malpractice insurance and malpractice cases. And when you look at the statute of limitations for bringing a suit from a birth problem, that's 18, 20 years. So that stays with you for a long time. And I've had my share of those cases as well. They were very difficult. And I wish perhaps if I had a better grasp of what I was facing, I would do it again. I wouldn't change it, but I never realized how difficult it was because you take those suits personally. I had a friend of mine who was OBGYN who knew the president of Boeing in Seattle. And the president of Boeing told this friend of mine, if I took lawsuits as personally as you do, I couldn't do anything. It is just a cost of doing business. Physicians have a hard time saying that. And I don't think that I would put it that way either. But I think we need to look outside of ourselves and say, things sometimes happen and don't happen well. And sooner or later, it's going to happen to you. And you have to deal with that and realize that you're not perfect and learn from it.
Yeah, that's probably something people maybe don't consider, this business side or this real world, outside the clinic side of medicine, that there's ramifications of that too. What would you say, like, I mean, you mentioned that you have had cases come up against you in those kind of situations. How does one prepare for that? How does someone, deal with those kinds of setbacks? Well, I wouldn't say setbacks. Let me say, how does one deal with those kinds of challenges?
I don't think you can really adequately. It's like a mystical experience. Mystical experience can be defined as this: if you've had it, you don't need to explain it because you know exactly what the person's talking about. If you hadn't had the experience, it doesn't matter what the person says, you'll never be able to understand it. You've got to go through it. And I think that's probably the way you need to do that. But there are services and supports that can help you work your way through these. But I don't think there is anything that you can really do to. It hurts. It's painful.
Yeah, that does sound challenging. Is there any techniques that you use to like pick yourself up off the ground, or like to recalibrate and you say, yeah, you know what, I am a wonderful physician and I'm a good person when those things happen?
I listen to my wife. Social support and support of friends and of colleagues is so important in those kind of times, because you feel so alone otherwise.
That's good. We're talking to Dr. Elmar Sakala, class of 1973B, about OBGYN. More from him after this break.
This episode is brought to you by the Student Ambassador Program of the Alumni Association, School of Medicine of Loma Linda University. Did you know medical students can receive honorariums starting at $500 for encouraging Loma Linda medical alumni to become members of the Alumni Association? Simply have alumni credit you in their perpetual membership upgrade. Help us build our community today. For more information, visit llusmaa.org/student-ambassador or call 909-558-4633. Support also comes from the Lending Library of the Alumni Association, School of Medicine of Loma Linda University. Did you know that the Lending Library has allowed students to complete medical school at Loma Linda University without purchasing a single textbook? Take advantage of the wide variety of medical textbooks and review books available, as well as a number of free books students can keep. The library is open 8 a.m. to 6 p.m. Monday to Thursday and is located at the Alumni Center on Anderson Street. For more information, visit llusmaa.org/lending-library or call 909-558-4633.
Welcome back. We're talking to Dr. Elmar Sakala, class of 1973B, about OBGYN. Let's now take it back to the daily practice of OBGYN. What does your patient population look like? What's the typical outcome of these kind of patients?
Well, a lot depends on the kind of practice that you're in. Let's take a community practice. Typically, you're going to have a multi-specialty group. When I started, there were a lot of people who were independent practitioners, but you can't do that anymore. So you have a multi-specialty group and you have your schedule. Typically, the outpatient seeing patients in the office will be a good 70% of the time. And then surgery, minor surgery, major surgeries would be perhaps 30% of the time. So you have a lot of outpatient care. That would be in your general OBGYN who is in the community practice. If you're in a subspecialty, that makes a big difference. And there are 4 subspecialties in OBGYN. There's maternal fetal medicine, which I have my training in. There's reproductive endocrinology and infertility. They call it REI. And that does a lot of the in vitro fertilization and the infertility. Then there is gynecologic oncology, which deals with cancers of the malignancies of the female reproductive tract. And then there is pelvic floor surgery. So those, you would have far more operating time compared to the general practitioner who's in the community.
Mm. And does it change based on like whether you said, based on if you're in a practice that has lots of specialties versus one that's in the community? How about academic settings versus private settings? Is there a difference there?
It depends. A lot of private, like we have in Loma Linda, general OBGYNs, and then the subspecialties. And the general OBGYN probably sees in their practice similar to what the community doctor would see. But the community doctor tends to do this, which I think is interesting. As a young person entering practice, you will probably see more obstetrical patients. And as the years go by, and you are often a primary care provider for your patients, They will enter the perimenopausal years and then the menopausal years. And as you follow them through your practice, through the years, you switch from primarily obstetrics to less and less and more gynecology. And I think that probably fits with your capacity to deal with all night on calls.
Oh, interesting. Let's talk about that for a moment. What is the hours like for someone, in this specialty?
Again, you are the one that can determine what your schedule is like. And you need to pick a practice which will allow you to do what you want to do. Let me just say that 90% of residents now in OBGYN are female. They're young women. They're women who want to have a family and who want to be able to spend time with their children. It's very difficult to have a full-time practice and raise a family at the same time. And so a lot of women will look for part-time positions. And I think that is doable. And I think many of the organizations like Kaiser recognize that and make the openings so that you can have that kind of a thing. But you need to determine what your lifestyle is going to be.
Yeah, that's a good point. Just taking into considerations the factors outside of what happens in the clinic setting. Now, maternal fetal medicine in particular, what does that specialty look like on a daily basis?
Okay, you have inpatient high-risk patients, either those who have not delivered, who would be called antepartum patients, who have perhaps medical complications, diabetes out of control, thyroid disease, lung disease, heart disease, whatever. Then you have those who are intrapartum, who are being delivered, and then those who are postpartum. And you may actually have patients in ICU, intensive care units, who have really severe heart and pulmonary complications. So that is going to be the inpatient care that the maternal fetal medicine does. And then we have our clinics in which we see patients who are referred with high-risk pregnancies, either maternal or fetal problems, a lot of ultrasound, a lot of obstetrical ultrasound. And you have to be good at what you're doing because you can't miss diagnoses. And so you have to meet the requirements of the accrediting bodies like the American Institute of Ultrasound and Medicine. But there is far less surgery done by maternal fetal medicine than, for instance, gynecologic oncology or the pelvic floor surgery.
That's good to know. So yeah, less surgery, more clinic.
Much more.
Okay. Now, you mentioned a bit earlier how, you start off, you might see more, deliveries and as they grow older, you see more OB. Do patients tend to stay with OBGYN practitioners over the course of their life? I mean, obviously people move, but those who stay in the same location, do you tend to see those people?
I have not done very much general OBGYN. Most of mine has been maternal fetal medicine. But when I was taking my residency at University of Oregon Health Sciences Center, I got to meet many of the general OBGYNs who were practicing in the community. And yes, they would see patients and follow them for decades and decades. In our society, as it becomes more mobile and people move, obviously that's going to change. So things are different now than they used to be 40 years ago. But there's a lot of people who, you will follow on an ongoing basis, and they have confidence and trust in you. And, there are things which you can't put on a chart, which you remember in your head about patients. And so when you see them, immediately it all comes back to you. You don't have to review the electronic medical record going all the way back. What was this? What was this? You all have that. That really is rewarding because it's like you're seeing a friend, not just a patient.
Yeah, that would be very rewarding to constantly go throughout your day seeing friends, so to speak. Now, Now, you mentioned mobility and people moving around. Is this a specialty that you could basically pick up and take anywhere, even to rural America, and practice?
Absolutely. Each state has its requirements for practicing medicine in their state. But the governing body for specialty is American College of OBGYN, and they are over the entire country. So your training in California will serve you well should you go to Mississippi or to North Dakota or to Wyoming or Maine or wherever.
That's good to know. And for those considering, the financial aspects of OBGYN as far as they making career and specialty choices, how does OBGYN rank in say, the salaries of a physician?
I figured you might ask that. So I did a little bit of research, and the numbers are variable, quite variable.
Okay.
I think you could say that you have the high earners, orthopedics, neurosurgery. You have the low earners, which is pediatrics, psychiatry, family medicine, and OBGYN is somewhere in the middle. And I think I would probably say the median income would be about $250,000 for OBGYN. But there is a lot of geographic diversity. Down south, I think you probably would get less. More to the northeast, you would get more. So it depends a lot.
And that's to be considered also, because I'm guessing there's cost of living and needs, and as specialties become more in demand and less in demand, their salaries will fluctuate a little bit.
And of course, there's always the student loans that you now have to start paying back. And that can be just enormous. What is it for Loma Linda? I think it's probably $120,000 or more. I mean, it's huge. And particularly when you have to start paying interest as well as making payments on the principal, that's going to take you 10, 20 years.
Yeah, there is that another financial aspect. I'm not sure what those numbers are, but yeah, I'm guessing that's a big financial implication to take into consideration, hence why people sometimes look at salary. Now, if
I could also say that this is the time when you're wanting to buy a house, you wanted to start a family, you have a lot of cash outflow, which you need to be dealing with. Later on, you'll have more money, but you really don't need it as much as when you are in your early years.
Let's talk about that for a second. In your early years, as you get out of residency, you are in debt, you are starting a family, you want to buy a house. How is that trend? What's some advice and trend you can give to people making that transition? Because there's no student loans available anymore. And then there's residencies not going to be paying you a ton. Like, what are some advice there?
It's easy when you get out. Lenders are more than anxious to get your business. And it's easy to say, now I can buy everything that I ever wanted. And you see these hot items, these expensive toys, and you're over your budget. It's easier to spend more than to spend little. So start out conservative and then make your way. But, after you've had so many years of deferred enjoyment and satisfaction, now you say, finally, I'm out. Now I can buy all of those things that I wanted. And I would say, be careful, because you can get in over your head. And unfortunately, there isn't very much financial assistance, not financial education that takes place. I wish there was more to prepare you for how do you deal with this kind of stuff.
Yeah, that is a very good consideration there.
But when lenders know that you will have an income which is significant, they're tumbling over each other to try to get your business.
Must be nice to be wanted then, hey?
Yeah, but wanted only for what they can get out of you.
Oh, so what's the word? Exploited then.
Exploit. That's right.
Now, you're in a unique position or a specialty, I would say, that you are a man in what you're describing as now a woman's world. What's that like?
Love it.
Hmm.
You know, the only limitation that I found of OBGYN was that you really did not deal with the males. But it's not entirely true because they were part of the team as you were working through different pregnancy and other issues. But if you don't like women, don't take OBGYN. But I have always respected women. I have got along well with women, and it's been very rewarding for me. If I could say this, Calvin, that 90% or more of first year spots in OBGYN residencies are filled now with women. It used to be that it was more men than women. And I don't think that's a bad thing, but I think that many times males who would do very well in OBGYN and would enjoy it feel intimidated and say, that's just a woman's thing. If you have a passion for it, if that's what gets you up in the morning and gives you energy, go for it. Mm. And I think at Loma Linda here, we are certainly looking for qualified male residents. We don't accept based upon gender. A good male, we want to have. I think they round out the program.
Yeah, each brings their own perspective. Now, I'll ask this question. I mean, in this world of, we've had the Me Too movement recently, and these movements that guys have to be, let's face it, a little bit more careful about their interactions with the members of the opposite sex. How does that play into your professional world as well?
Well, absolutely. We always insist on having a chaperone who is present in the examination. And it used to be that it was primarily the males who needed to do that. But I think in today's climate and with the LGBT communities, females need to have the same protection by having a third party in the room to make sure, not to make sure, but to give the comfort and security that is needed. Mm-hmm. But yeah, that is a very important. I mean, you take this guy Nasser, who has been jailed for life now for assaulting all of these Olympic athletes. I mean, that's a tragedy. It should never have happened. And it could have been prevented.
It's very, very important, both to protect the patient and also, a well-practicing physician who doesn't want to have that on their record just for an accusation, per se.
And, there are patients who will misread what you're saying and what you're doing and will bring against you things that you had no idea that you were doing. And that's why it's always good to have a chaperone present.
Yeah, very important. Now, let's shift focus for a little bit now to you're a professor. You've been a professor in Loma Linda for a long time. What's it been like, as someone who is interested maybe in being a teacher, in academic medicine? What's that career path like? How did you get there? Can you describe that to us?
Well, prior to entering medical school, I got a Master of Arts degree in education. And education has been an important part of my life right from the get-go. And in fact, if you would ask me what word would define you better, educator or physician, and I would say educator. So that was really important for me. And of course, I think even in a private practice situation, you need to be there to educate your patients, because the more they understand, the safer you are. I never wanted a patient who would say, "Doctor, whatever you say, I'll do it. Whatever you say." No, I want patients who would ask me questions, who want to know information. I think you're far more protected. So education, I think, is an important part of that. Now, in terms of the academic situation, working with medical students, I was the program director for the medical student program for a decade in the early 1990s. And then working with the residents. That is an additional level of education, separate and distinct from patient education. And that, of course, is so rewarding because you have what we call the multiplier effect. Here you are, and you're dealing with these dozens, if not hundreds of doctors who will go out and who will hopefully reflect what you have taught and hopefully be benefit to the world. And that's what we're all about here at Loma Linda.
Mm-hmm. Mm. And that's got to be both, I would say, satisfying and fulfilling, as well as that's a big responsibility, knowing that, you know, the lessons and the techniques and the information that you impart will be taught down the line. How does that feel?
Let me just give you some information here. What were the influence of various factors on the specialty choice of graduating medical students in 2019? What were the influences on them? Number one, personality fit. 99% of students wanted something that fit their personality. Number two was specialty content, 98%. But the third one was role model influence. And as a physician educator in an academic setting, you are a role model. And you are communicating often more in the things that you don't say, but you do, than the words that come out of your mouth. And that's a big responsibility.
Mm. As someone who aspires to be that person, to be that leader, that influence, if someone there is listening, you know, how does someone, say, who's in their fourth year now, how does someone who wants to be that influencer, that person who imparts knowledge, how do they get on a career track to get to where you've been?
Well, you would hopefully sort out people who are doctors who are user-friendly and who are interested in spending time with you as a student physician. And we would have in the fourth year electives where the students would come back and are kind of like sub-interns who are carrying more responsibility because they are beyond the third year, which is what most students see OBGYN as. But get to know the user-friendly faculty and ask if you can shadow them around. You know, what did they do in their making their choices? And that, I think, can be very, very helpful.
And what sort of skills do you think are essential for someone who wants to become a professor in medicine or in other areas too, but specifically medicine?
What I like to say is I like to make complicated things simple rather than making simple things complicated. And some of the lectures you go to, you come away and you say,
over your head, yeah.
A good teacher makes complicated things simple. Mm-hmm. And that's what I like to do.
Okay, that's a very, very good point. Now, you know, looking back on your career, you know, you've been doing this for a long time. Are there any specific stories that you can share? Not trying to break hip or anything, but just any cases that you can share that you were like, man, that was so gratifying. That's why I do what I do. Yes,
I do have one. Well, more than one, but this one stays in my mind. What the public calls Siamese twins, the medical world calls conjoined twins. And this is where you have two fetuses who are sharing certain organs or parts of the body. Most of conjoined twins do not survive. They occur about 1 in 50,000 births, so they're very seldom that we even see them. And in my career, I've probably seen a half a dozen sets of conjoined twins. And I still remember the pastor from Arizona called me and said his granddaughter, or his daughter is pregnant and was diagnosed with conjoined twins. Would you be willing to see her? So I said, sure. So she came to see me. I did the ultrasound. And one problem, the most common issue is that they have a heart which is shared. And they won't survive because you can't divide a heart up. As I was doing the ultrasound, the heart and the chest were separate. The umbilical cords were fused, so they both used the same umbilical cord, but the liver was shared. But they had separate bladders and gastrointestinal tracts. I said, I think these can survive. And so we followed them all the way through. The pediatric surgeons worked for months to prepare for the surgery after delivery. And I will never forget, in surgery, I did a cesarean delivery and took out 2 babies at the same time. And they were silent when they first came out. And suddenly they started screaming and shouting. And I said, thank you, Jesus. And those babies grew up and were, they were separated successfully. And they are both doing well.
Fantastic. How old would they be today?
Today, about 25.
Okay.
Yeah.
Wow. Now, when you said praise Jesus and stuff, does faith come into your practice and what you do as a physician at all?
It does for me. When we're talking about difficult times, pregnancy losses, infertility, dealing with those kinds of situations, what is it that brings strength and gives you the courage? And so I ask patients, what is it that gives you courage to go through this? Are you a woman of faith? And if they say no, that's fine. But if they say they are, then I say, I want to help you and assist you. Would you like me to pray for you? And I've only had one patient say, no, I don't want you to pray for me. And I have made a practice of doing this before surgeries as well. And people would say, yeah, but when you pray, it makes it sound like you're not a very good doctor, and the only way things will turn out well is you pray for them. I have never had that happen.
Okay, that's great. Now,
if I could just say, that touching of the hand, to hold the hand while you're praying, can just make just a huge, huge difference.
Well, thank you, Dr. Sakala. Before we go, we've used it up. We're headed towards our allocated time here. I just want to know, advice. I mean, a lot of our listeners will be mostly students, mostly residents. Looking back and looking, even now, what advice would you give, people starting out in their careers in the field of medicine?
In medicine, oh boy, don't go into it for the money. Go into it because of what you can do and serve. Because the money will be there. It is not going to bring you the happiness. It is a relationship with your patients. It's a relationship with your family. And to maintain that balance, that I think is really key. Because you can lose your family. In fact, when I was in my residency, I had one doctor who was in private practice, and he said, he is not married to his wife. He is married to his practice.
Wow.
I thought, what a fool. Because he lost his wife. He lost his family. That's not a very good note to end on, is it?
Do you want to give another piece of positive advice? No, it's very important to talk about these things because, these are the practical aspects of life that people will, no doubtedly, not everyone, but people will go through. So that it's very valuable advice. Thank you for sharing that. But if we do want to end on a more positive note, is there anything else that you'd like to share that's a little bit more upbeat?
It's the main thing is that you need to have a passion for it. I have many students who end up in a primary care setting, not because they chose it, but because they couldn't get into something else. OBGYN residents do not get into OBGYN because they couldn't get into something else. They do it because they have a passion for it. And I think that's really, really important, because that will maintain you as you go through your years.
Mm-hmm. Some solid advice there. So Dr. Sakala, on behalf of everyone listening, I just want to thank you again for taking the time out to speak to us and not only just share about OBGYN, but of other specific and very helpful practical tips for them. So thank you again.
Thank you, Calvin. My pleasure.
Thanks. Ask Alumni is a podcast of the Alumni Association. If you'd like to hear more about episodes like this or other podcasts that we produce, please visit our website at lousmaa.org/podcasts. And if you have any questions or would like to see a specialty featured on this podcast, please email us at lousmaa@lou.edu. For now, I'm Calvin Chuang. Have a blessed day.